show is in honor of, it's a show for veterans and their families, and we bring you information that is most important to your life. Okay. We have very special guests with us today, and I can't thank her enough because she brought with us the leaders of the VA in oncology, palliative care, and liver disease, and I can't thank you enough because you bring us so much important information. Dr. Aytaman, okay, and of course, before we started, my co-host Paul Dietrich on the other side. Dr. Aytaman, who did you bring with you today, and is there any news that you have for that's?
Thank you, Ed, and thank you, Paul, for inviting us to be here today. I brought you today Dr. Leaf, who is our oncology chief, and we brought also Dr. Beal, who is in charge of our palliative care. And we want to really change the concept, the way you think about palliative care today. And we have also Dr. Doratsos with us, who is our social work representative, who just finished her PhD in Vietnam War veterans-related cancers. So it's a very distinguished panel. Dr. Leaf was trained at University of Buffalo, and residency and fellowship is at NYU. And Dr. Beal was from Tufts University, and pulmonary fellowship and residency, pulmonary critical care and residency were at NYU. And Louisa was trained at Vassar, and afterwards did the master's at SUNY Albany and PhD at Yeshiva University. So we are hoping that we can bring you some news about the common cancers inflicting our veterans. How do we screen them? What do we have available for them? As well as we want to talk about the concepts of palliative care, the changing ways we are approaching our cancer patients.
Well, let me say welcome, ladies, and thank you so much for taking time out of your very, very busy schedules to join us on this program. And I'm sure that the veterans that see this on the air, on television, and on YouTube, of course, we're on YouTube with all of our programs, they'll find this very helpful to them as you go forward.
Can you give us any updates on Hep C and your current
I knew
work?
you were going to ask me that.
Absolutely.
So I just got back from the liver meetings last night in San Francisco, which, by the way, is under a heavy cloud with those heavy fires. And VA data really rocked at the meetings. We have treated 120,000 veterans with 95%, 96% cure rates. So it's very difficult in the VA to find any veteran who needs still Hep C treatments. The ones that are left have a lot of barriers to treatment or don't want to get treated for various reasons. So excellent data with huge impact on overall outcomes. We now are realizing by curing Hep C, we are not only decreasing the incidence of liver cancer, liver-related mortality, but also all-cause mortality, and all cancers are on the decline in that veteran patient population.
Excellent. Of course, we talk about the veteran population, and of course, what we're talking about is those that are actually in the VA, and we have a large group that are not, and we have some that also are not eligible. And it's important that even if you're not eligible, that you consider going and getting screened for Hep C, because it is such a life-changing event when you are cured from it. And we've had other people on the show before, including some of the veterans, and it's just totally changed their entire lives around.
The American Liver Foundation did a video with one of our veterans, Vietnam War vet, PTSD, 100% service connected, liver cancer, liver failure, hepatitis C, transplant in the VA system, and cured. He made everyone cry, really. That video soon is going to be available, and we will put it on the VA Facebook also, hopefully. And it's really a very, very important story. And I want those veterans who still are hesitant to be checked and treated, please reconsider that.
Yes.
I borrowing a line from Louisa, if you forgive me, but we were talking earlier, and what she said, and I'm going to try and quote it, was you see all of the advertisements on television for the wonderful things that some of the hospitals are doing in these various areas, and the funny part is the VA has been doing it for years. What the hospitals are talking about doing now. So the VA has always done it. Then I have a question for the entire panel. Do you have a way of screening for the most common cancers?
Well, certainly we do. One of the most common cancers that we see at the VA is lung cancer, and especially given our patient population. So, and for many, many years, there were no clear guidelines on how to screen for lung cancer. We know it's a very deadly cancer in many cases, and people were looking for ways to screen for it. And it was only in the past few years with national studies and now even some European studies that have shown that there is a real benefit in mortality from lung cancer and overall mortality in screening for lung cancer. So as soon as those guidelines came out, the VA chose to adopt those policies nationwide, and actually our VA was one of the first in the country. They chose about 6 different VAs to kind of roll out this program of screening for lung cancer because it does involve many different disciplines. It involves having the proper equipment to screen for these low-dose CAT scans that are used. We need radiologists who can evaluate those scans appropriately. And then when we find all of these lesions on CAT scans, we need the proper pulmonary lung doctors to try to find those cancers. And sometimes it's very difficult. Sometimes we're finding them when they're very, very tiny. And we need lung doctors who can have the expertise and the equipment to try to find those tiny little cancers. And they're using it. They're using now even using GPS technology to try to find those tiny cancers in the lung. So that's really wonderful. And then even once we find them, we have to have a way of treating them. So, you know, either surgically, and we do have oncologically cancer-trained lung surgeons who could deal with that. And on occasion, patients may not need surgery if the lesions are very small. And sometimes it's our radiation oncologists who could deal with these with just radiation therapy. And we have radiation oncologists now who have using state-of-the-art radiation therapy to try to treat these very small cancers. And the cure rate has gone up.
And this is all recent, the changes? The change is really, it's really over the past 5 years or so that we've started, people in general have started screening, and we at the VA have started screening for lung cancers. It's amazing. So wonderful things are happening.
Right.
And all to benefit the veteran and their family.
Right.
And
I think the most common cancers afflicting our patient population is lung, prostate, and colon. Those are the top 3. And liver cancer now is also in the top 10. Pancreas is right next to it. And out of all these cancers, the good news is most of them are on the decline in terms of mortality. We are doing so many good things that people are not dying from it, except for liver and pancreas are still on the rise in terms of mortality, dying from it. So I can speak for the colon cancer. Colon cancer, I am now finding only in veterans who either refused the colonoscopy, didn't want to get screened, or they are entering the VA system anew, and we are finding their cancers because we screen. And the other interesting fact about colon cancer is United States is the only country where the cancer incidence for colon is declining. Not only the mortality, because we do a lot of colonoscopies. Other countries cannot afford this many colonoscopies. They screen with blood in the stool or immunohistochemical tests in the stool or genetic tests in the stool. Those are all recognizing early cancer. But the cancer is there. You have to treat it still.
Colonoscopy is beforehand.
Colonoscopy removes the polyps, which is the forerunners of the cancer. We basically lasso them and burn the base of it and remove it. And that actually decreases the incidence of colon cancer. You don't develop it. So we have been seeing that in our own facility. We have seen the cancer rates dropping significantly with that by about 50%, which is very significant, but we do preferentially colonoscopies. So that's colon cancer, and then we have the liver cancer, which we see in high-risk groups, like our Hep C patients with cirrhosis or hepatitis B, or other causes of cirrhosis, and fatty liver is now becoming a big contender leading to cirrhosis and liver cancer. We do have screening with every 6 months sonograms, and we do see a significant benefit of diagnosing these lesions early because we have curative treatments, including liver transplantation.
Are you seeing any theater-specific type of cancers, doctor?
Oh, yes. I know that a lot of our veterans are concerned, especially the Asian theater era veterans are concerned with the bile duct cancer or cholangiocarcinoma related to liver flukes. And liver fluke you can get the liver fluke from not well cooked fish or crustaceans and what have you. And once it gets into your body, it likes to go to the bile ducts and causes inflammation there. It can sit there for many, many years and then disappear, but the damage is there. That chronic inflammation over the course of the years can lead to bile duct cancer, which is really a very uncommon cancer, but it's still there. And we consider it a service-connected disability for our Korean and Vietnam War vets. The liver flukes differ a little bit between China and Korea, and more like the Vietnam, Laos, that area. And the issue is we do not have a good way of screening for past fluke infection. So if a Vietnam War vet comes to me and says, "Doc, did I get this liver fluke? Am I at risk?" I have no way of knowing because we do not have a test to screen for past liver fluke infection.
Only for
So
current.
VA is working heavily trying to get a serologic test, a blood test for that, and we are getting close to it. Soon we will have a test available, but currently we don't have it. We just look at the liver tests right now and a sonogram if the patients come to us concerned, and even that doesn't have too much evidence-based background behind it.
Dr. Leaf, what services are available for cancer care for the veteran in New York Harbor?
Oh, we have many, many services. As I mentioned before, we have a radiation oncology department with state-of-the-art equipment offering stereotactic radiation, kind of pinpoint radiation, radiation sources that can be implanted into the patient and so on, depending on the type of cancer. We have surgeons who, again, many of whom are trained in oncology, in general surgery, and in surgical subspecialties such as head and neck cancers, urologic cancers, and so on. And the oncology department, we treat all different types of cancers, major solid tumors such as lung, prostate, breast cancers, and so on, along with what we call hematologic malignancies such as leukemias and lymphomas and multiple myeloma. And the care now in general in oncology is getting much more sophisticated. We always had, and we still do, rely on chemotherapy, but now we are able to test the cancers for different genetic mutations and find out whether there's a particular targeted therapy for that particular mutation in the cancer. So now this is available throughout the VA, and it's a very critical and important step in cancer care. And immune therapy also for certain cancers is now routinely used. So we're happy that we're able to get all of these drugs. Any drug that I really need to treat the cancer with is really easily obtained. The VA.
Very good.
It's very exciting.
Yeah, and then we also have a lot of support services for our patients. Every new patient comes in, gets full psychosocial evaluation, and what they call a distress monitoring screen, looking at practical issues, family issues, emotional, spiritual problems, physical problems, substance abuse problems, smoking, and so on. And then that patient is referred to one of our oncologic psychologists who meet the patient, and with Dr. Doratsos from Psychosocial Services, who also meets with the patient and their family.
That's got to be one of the most important things, because in days gone by, you would get the diagnosis that you have a cancer, and the first thought in your mind is, I'm going to die. I'm going to die, and the world just comes crumbling down. And that's not the case anymore. It's not the case anymore. There are things that can keep you going and make you better.
It's unbelievable that we are using now the body's immune system against these tumors, and those treatments are revolutionizing really the cancer care. I think the cancer is becoming like a chronic disease.
In many cases,
in many cases, of course, they are cancers that come like a brush fire. No matter what we do, we cannot help. But for the most part, especially if we can diagnose it early, we have a lot of tools. And the other thing is we are changing our approach, as Andrea mentioned and Luisa mentioned. Alice can tell us what we mean by palliative care. Because when I tell my patients, I'm going to send you to palliative care, they say, oh my God, Dr. Aytaman is not telling me, but I am dying. So,
and though the treatment for cancer has improved dramatically, getting the diagnosis is still really traumatic.
Sure.
And no matter what it is, it's a panic first. So it's really wonderful that we have palliative care early. And in early palliative care, we just try and find out what the patient's symptoms are, try and figure out what their goals are, that they understand what the disease is and who we have to help them and what services we have to help them. And palliative care is a interdisciplinary service with chaplains, psychologists, social workers, physicians and nurse practitioners as the core group. And we work with people to make lives as good as possible, to make people understand their disease or allow them to understand their disease and their and what to expect. And very often we will see patients and then not see them again for another year or so, which is and that helps because when they get sicker, we know them.
What era do we seem to be focusing on, and is there a more importance put on a Vietnam veteran?
Well, at the moment, the Vietnam veteran population is the largest population being treated, certainly inpatient at the VA. There are 7.3 Gulf War veterans and only 6.7 Vietnam veterans. But when you get the age difference, it's the veterans in the Vietnam era that are using it more and more. And then there's a big drop-off now to Korean War veterans and less than 1 million World War II veterans at this point. So it's the Vietnam veterans that we're concentrating on. And Louisa knows the Agent Orange registry quite well, and we try to make sure that our Vietnam veterans get everything they're entitled to if they've been exposed to Agent Orange.
On behalf of all the veterans, I can't thank all of you enough for what you've done, for the many thousands of veterans out there who need your assistance and receive it. And it's just a great thing that you're doing.
I do think, however, though, that at some point you will see the veterans of Iraq and Afghanistan, because I can tell you from my own experience there, the dust is absolutely horrendous. They burn all types of garbage and everything else gets burned. And all of that is in the air and was breathed by those of us that served there. And I think that down the road we're going to have another group coming in.
No question. No question.
It's just, I can't believe that it will not happen.
Yeah.
That's
And the projections are that in 2027, there'll be 8.2 Gulf War veterans. Yeah. And in 2037, it'll start coming back down to 7.8 or so. So we're on the rise, and we don't know all the service-connected diseases from
so I see in my own body a change from having breathed that for 2 years. And I just can't imagine the rest of the population that was out there with me and what effects they're going to have on it.
So the burn pits from the current veterans, there's actually a registry that veterans, I believe, should sign up for, and that's going to allow the VA to immediately contact veterans if the VA finds through public health information that veterans are getting a specific kind of disease or diseases, which might be able to, through medical research, find that there's a cause and effect between what they have and their service. And this is similar to kind of go back into history with what happened with Agent Orange with Vietnam era veterans, where it started with one disease. It started with prostate cancer when men who went to Vietnam started getting prostate cancer at an unusually early age. Over the years, the list for Agent Orange diseases has expanded. Sure. And by the way, it isn't just cancer, it includes diabetes and it includes heart disease.
Absolutely.
And then most recently, maybe about 3 years ago at the most, the water at Camp Lejeune from the early 1950s to 1987, I believe, was found to develop its own list of diseases. So any Marine who has who was at Lejeune for any period of time, actually it's 30 days, at least 30 days, may be entitled to become service connected from the VA,
But
and you
at the
don't
very
have to use.
least, they need to be screened.
They need to be screened. They need to be
On the
acknowledged. And so for Camp Lejeune veterans, you can actually get on the registry and say, "Hey, I was at Lejeune." Again, if there are any updates, the VA will be able to quickly contact you. And there's also now for Afghanistan and Iraq, there's a burn pit registry.
So how does one get on that registry?
So the best thing a veteran can do, especially a veteran who doesn't use the VA, is to become acquainted with one particular website. I mean, there's a lot of great things in the VA national website, va.gov, but there's a particular web page regarding diseases, and it's called publichealth.va.gov. And it lists all kinds of diseases, different war eras. For Navy veterans who were in Vietnam, it even has a list of ships which were actually considered to be in Vietnam, or ships which were considered to be blue water veterans. So these are important pieces of information. And there's one piece of VA research which is really interesting. Back from the last survey of veterans, there's actually a census for veterans every 10 years. And what it shows is Vietnam-era veterans know less about their benefits than World War II veterans did and Korean War veterans did. And that's really important. They know less about the benefits that the federal government actually gives you. So what's our responsibility? We're supposed to educate as much as possible. And it's so great that you have a program to educate people who don't use the VA.
I think part of that may be the reception that Vietnam veterans in particular got when they returned.
Sure.
Yes.
It was much different than the response I got coming back from Iraq. And I think that turned off quite a few veterans. They wanted to go back into the quiet places and not be acknowledged as a veteran even.
Right.
So,
But they should know that when people ask me, which one of your children do you like more? Which is a ridiculous question, but I tell them, whoever is sick at that time. So if they ask me, which one of your veterans do you like more? I say Vietnam War, because they were the most mistreated.
yes.
Others also, but to a bit lesser extent. So they should know that, and they should come. It's more difficult to gain their trust. There is no doubt. I mean, I have more difficulty gaining their trust. Eventually we do. But we want them to come so that we can screen them, so that we can tell them about their benefits. So
Then there's a phrase, and it's called veteran-centered care. And that's everybody's objective, whether you're, a medical doctor, a surgeon, a nurse, even, housekeeping clerk. We want to make sure that when you come into the VA that you get the very best care, and that we understand as much as we can about veteran identity and the veteran experience. So there are actually a lot of people in the VA who are working very hard to deliver that care and to show what that model looks like.
Yes.
I just want to say something. Disclosure, we are not perfect. I mean, these are things that we are trying to accomplish, but you might come and a clerk might immediately avert you against the VA by being rude or disrespectful. So what we need from the veterans is immediately go to the patient rep and report that person, because your voice counts in the VA. My voice is your voice, but your voice counts more than my voice. And change it. This is your system. This was created for you. And if you don't like something, raise your voice, change it.
The other thing I would caution the veterans that if you do not use the system, it will go away. The system is there for veterans.
Absolutely.
It's designed for veterans. And if we do not use it, it will disappear.
Everything is numbers. We do have the capability of moving our veterans to the best healthcare systems if we feel we don't have the capability to do something. For example, radioembolization we didn't set up in the VA because it was too cumbersome and too few numbers. So we send our patients to NYU for that. We do have the capability to send veterans to community care if needed, but I really think looking at veterans who go to community care and then come back for various reasons, nobody can take care of veterans like we do. That's my strong belief. And if you don't use it, you're going to lose it, like
Yes.
Paul said. We need
I
numbers.
mean, that's a political reality.
Exactly.
Yep.
Let me say this, from what I've seen, especially in the New York area, the VA system not only does it work, but it's the greatest option that you have. It's amazing. I read all of the negative press from Arizona a couple of years ago, and that's not New York. Let me tell you, it's not New York. I talk to veterans every day, and I see the veterans that use the system. Here on Staten Island, they go over to South Avenue, they go into Brooklyn, they go into New York Harbor Care, and I have nothing but kind things and good things to say. I mean, the biggest complaint I've heard about the VA is there's no place to park in Brooklyn.
Oh, this is our joint complaint. I think
And that's our goal. That's our goal. We're at the VA hospital because we love being there. We love the population.
Dr. Doratsos, how do patients find out about Agent Orange illnesses, and if they have them, what treatments available, and how does it apply?
That's a great question. If they come to the VA and they get diagnosed with a cancer and they come to the new patient clinic, they will, as part of their initial visit, get psychosocial distress screening, which is also, it's one of these national initiatives with VA and non-VA hospitals. It's actually required by the Cancer Program Accrediting Organization called the American College of Surgeons. So we're certified that way, and we follow their prescriptions where everybody who's diagnosed at their first visit gets a distress screening. And then they sit down with me, they'll sit down with our psychologist as well, and we'll go over some of the issues in this simple tool. But we'll talk about their housing, we'll talk about transportation needs, we'll talk about their emotional needs, we'll talk about there may be, extremely distressed before they went to see Dr. Leaf and the other doctors associated with the team, and they may feel a little bit better once they know the medical facts, but they still have other concerns. Maybe they actually had a bad incident as a result of their military service. That's not PTSD, but could be something else. So in speaking to us, we'll screen for things, including what era did you serve and where were you? And it just happens to be an interest of mine, so I can look at somebody like you and say, oh, you must have been, Vietnam era, or tell me, what branch were you in? When did you, where and when did you serve? And it's surprising to actually meet veterans who used the VA for years and never realized that, using the example of diabetes, that their diabetes is considered Agent Orange related. Yeah. And we have great technology at the VA, so I'm able to print the part of the website that discusses it and actually send them to a veteran service organization, which will help them file a claim.
And I mean, these diseases now for Agent Orange are presumptive.
Right.
So, and if you don't know what that means, it means if you have this disease and you served in Vietnam, for example, it is presumed that the disease came from your service.
And on page 1 of the Agent Orange handbook, it says if you had boots on the ground for 1 hour in Southeast Asia, your disease, your lung cancer, your multiple myeloma, your
Heart disease.
Your heart
Ischemic heart
disease,
disease.
ischemic heart disease, your prostate cancer. 1 hour boots on the ground, you're entitled. And I always consider it one of the few times where the little guy gets what he actually earned the hard way. And for Camp Lejeune, with the Camp Lejeune diseases, which include multiple myeloma, Parkinson's disease,
There you have a
bladder
lot of family
cancer,
involvement also.
bladder cancer, kidney cancer, 30 days in Camp Lejeune from 1953 to 1987.
And again, those are presumptive at Lejeune
Presumptive,
also.
yeah,
Yes.
presumptive. And we're already helping Marines get 100% service connected. I can think of like 3 on treatment right now that we helped.
We talked about service connection, and we have talked about it before, but I think it's important that we talk about it again. And yes, I have a service connection for hearing loss. It's
Right.
not marital deafness. I can't claim that to my wife anymore, but I did actually lose part of my hearing in Iraq. So could you talk about service connection and how someone would go about getting service connected?
So the simplest way to discuss service connection is whether or not you were actually in a war era or whether or not you were in combat. It's something medical or psychiatric, psychological that happened to you while you were in the service. And it was bad enough that you have medical records to prove it on your DD-214, on your discharge papers. So that shows the medical condition. The best example is, somebody who stepped on a mine and lost his leg in an IED incident. Then the person has to then apply to the VA to say, my leg, was lost in this accident. Here are the medical records from my service. And you get designated money, which is, we speak of it in terms of percentages, which means how much money you get each month. So how you get it now, all these years after you've been out of the military, something happened to you, you were in Vietnam, and now you have lung cancer. Your lung cancer, as I said earlier, if you spend more than an hour boots on the ground in Vietnam, is presumed. You don't even have to prove anything other than show your current medical records what your lung cancer is. And by applying to the Veterans Benefits Administration through a service-connected claim, it's a particular paperwork process. Best done, my opinion, is through a qualified VSO, Veteran Service Organization. You can do it by yourself, but you may miss things. Rely on the people who've done it over and over again. And people with these, especially with the presumptive diseases, will surely get money. And if not for yourself, and I'm sort of speaking to the people who don't want to, as you said earlier about, the Vietnam experience, you just wanted to get out and just go put your head under the covers. You are doing it not only for yourself, you're doing it for the database that other veterans coming after you. Knowing that you have a disease actually gets into the database. So again, that's part of that public health database that's so important. And it does, although veterans benefits and the idea of the sacredness of veteran status goes back to ancient times, we all know that history is not being taught the way we learned it when we were in school. And these things could go away, even though the idea of paying veterans for their service in response to their injuries, visible and invisible, can go away. And it shouldn't go away because there's so many people now going to Afghanistan, Iraq, and all these other places I can't even imagine. And I have 2 young relatives right now on active duty. And I can't imagine when my nephew calls my mother and says, I'm not going to be around for 6 months, where he's going or what he's doing. It could go away for people like them. And so in the spirit of the veteran community, I believe it's important to apply.
Mm-hmm. I go back to what you said also about a qualified person that can help you prepare the claim. My hearing claim, I did not attempt that on my own. I went to a certified service officer. Any one of the organizations will do it for you.
For free.
For free. Yes, you can go and you can pay somebody to do it. There are companies that do this. But the American Legion, the Veterans of Foreign War,
DAV.
the DAV, all of these will handle your claim whether you are a member or not.
Exactly.
And yes, it does take time. It took me 11 months, but yes, they have convinced me and my wife that I'm deaf. Well, she knew a long time ago I was deaf, but that's a different story.
I also want to say for anybody who unfortunately has a terminal illness, like Social Security, you can, when you apply, if you unfortunately are very, very gravely ill, you can apply on an expedited basis. And the VBA, my understanding is, can turn around a claim in 10 days.
Expedited.
Expedited for the people who need it most, but it is possible.
What else is the VA healthcare system doing to ensure that the veterans' preference for healthcare are being met?
Well,
in palliative care, that's one of the things we concentrate on, that people know what their diseases are and their process and what the options are. And the VA, it's really thanks to our boss, Dr. Carol Lures, who is the chief of oncology and hematology and set up this whole program, and the head of palliative care works for the national palliative care. But in the national palliative care system now, there's a whole setup for allowing patients to understand and choose what their options are when they can no longer decide for themselves. So we have an initiative now that concentrates on people to rank what's most important to them. This is what's most important to me if I get sicker, or if I'm unable to take care of myself, and list it ahead of time, think about it ahead of time, and let their families and their providers know what's going on, what their wishes are, and then it gets readdressed as needed.
I have to also say, Dr. Lewis really created an exemplary program. Didn't she also get a national award for that? Several awards, and has been a champion in palliative care issues also. Recently, I had this patient, and even though I am so patient-centric, I love them, they love me, I really am just as much guilty of not asking them what they want. We always tell them, oh, we found this, and these are the options, and I feel for you, this is the best one. And they always say, okay, Dr. Aytaman. But now we are turning this around, and I am asking them, is there something going on in your life that's very important? So he tells me, Dr. Aytaman, in a month, my daughter is getting married. So that's very important. We arrange the treatments around that, not around our schedules anymore. So we make sure that he is in good shape for that wedding or for that graduation, whatever is important in his life. So we are creating these teams that work very closely, inherently. For example, we diagnose liver cancer. We have an unbelievable system. Let's say you went to the emergency room, they did a CAT scan because you had belly pain, and they found a lesion in your liver. The next morning, this will be picked up by my nurse tracker from the radiology database without any alerts actually otherwise. She immediately will alert the liver cancer coordinator nurse practitioner. We arrange the proper imaging. We bring the patient to the multidisciplinary, multi-facility tumor board with experts from Bronx, New Jersey, East Orange, Northport, Hudson Valley. Us, we get together via Scaneco virtually, and we make a decision, this is the best treatment choice for this patient. And then the next day we see the patient and give them the results. We have also beautiful patient information materials online that we created, and we give them that. And then if we think they are too nervous, one call to Alice, Dr. Beal will be at our site seeing the patient right then and there, or Louisa, or our other
Joanne Nergrazza.
Joanne is wonderful, our MP also, and they will immediately talk to the family, look at their needs, and comfort them, actually. Some patients don't show it as well. We arranged everything for next week the most, but most of our patients are seen very fast, and our diagnosis to initial treatment is less than 30 days all across the VISN, not only in Harbor. So that's a very good system, I
Doing
think.
wonderful things.
And if we know what's most important to the veteran, then we know why that veteran may not want to follow our schedule quite the way we'd planned, and we'll rearrange it.
We also have our doors open. We work with community hospice programs, and there's a national program called We Honor Veterans, where the local hospices are all members of this program, and they identify the veterans on their caseload. So we talked about veteran-centered care earlier. The VA obviously, hopefully, does that, but hospice programs are also delivering veteran-centered care. And if the local hospice program, determines that a veteran needs something that they can't provide, they contact us through the palliative care team, and we work cooperatively with them to help the veterans get a needed service.
And not only do we have inpatient and outpatient consult services in all three of the Harbor's facilities, Manhattan, Brooklyn, Queens, we have a state-of-the-art hospice unit at St. Albans, Queens, with 15 beds. And we are starting to do video consults for those patients who are too sick to come in. We can arrange for a video conference to see them, find out their needs, even get them registered if they're on hospice and haven't been at the VA.
So the Staten Island Clinic has the video room, and any veteran watching this program who needs a consult can actually report to South Avenue, and we can be back in Brooklyn and actually meet with the patient, talk to their doctors at the same time to save them a trip over the bridge.
And then sometimes we can even have someone in the home with a secured video to us so that they don't even have to come into South Avenue if they can't.
Younger veterans love that. They are more tech savvy.
Oh, yes.
And to establish something in their iPads or even cell phones, a virtual clinic visit connection, that really intrigues them, especially if they are working very hard and have no time.
Right.
Yeah.
But it's
I can see the younger veteran going for that.
Yeah.
I look for the payphone on the street, but there are no.
But fortunately, there's, when it comes to, the veteran who's too sick to come out, fortunately there's always somebody in the house who has the smartphone. And if we talk to them and talk them through how to upload our app, we can do the call with them. So the 95-year-old grandpa doesn't have to
That's
Do
good.
the app
FaceTime.
himself.
I have to ask my grandchildren.
You always need a
We all
young
do.
person.
Well, is there any last thoughts that any one of the doctors give us on you would like to, message that you would like to put out to the veteran who's watching this?
So no wrong door, and that's an expression that the VA homeless programs used for access into the VA homeless programs. But I think we can say for VA oncology care, there's also no wrong door. If somebody contacts us, we'll make sure that they get to the place that they need to go.
Is there a central contact number that we could put out to people?
So, as it turns out, one of my hats is I'm the outside contact for veterans who don't use the VA and don't have an assigned primary care provider. So I'm one of the access points of contact. Call me.
Is there a phone number though that you
Sure.
can put out?
I'll give you my office extension. It's 718-836-6600, extension 6366.
And I will send my MP's extensions. I can say them, but it's nicer if we can put it on a card or so. I will
Make a
send
graphic.
our whole liver team extensions are there, including our social work, psychologists, nurse practitioners,
We'll try and get that
oncology.
incorporated into the end of the
Exactly. And my last pledge is choose VA. Come to us. We can find you the best treatment possible. If we don't have it, I can assure you, we will get you to the best places. But let us organize your care.
Now, for those veterans who watch this on YouTube, who are out of the area of the viewing television people, let's say somebody's in Connecticut or Rhode Island or whatever, and they're impressed with what they're hearing today. Do they have the availability to come into the New York area and use the VA
First
system?
of all, we are truly a national team. I mean, we talk to each other on a weekly or monthly basis. I can tell you, as the liver team, I can connect any veteran within 5 minutes all across the nation, including Puerto Rico. There was a veteran, we got an email from, I think, Kentucky or so. The veteran was moving to Bronx to be closer to relatives. Within 5 minutes, we put them in contact with the Bronx team, and the veteran had an appointment within a week with seamless continuation of his liver cancer care. Any veteran who hears this and sees those numbers, they can even call those numbers and we will put them together with the Connecticut team. West Haven VA has a superb liver team also, and I know the oncology team there also. Incredible efforts, just similar to ours in palliative care. So we have a whole group of cancer providers all across the nation, completely networked together. It doesn't matter whom you see, where you see. So I'm sure there's personal preferences. I mean, they might like to see me or Luisa, but the doors are open and we are very well connected.
And that's important too.
Go on.
Sorry, and that's important too. When a veteran moves from one place to another, the computer system is set up such that any place that they are registered, the physicians there, the healthcare providers there will have access to their records. So if they are moving somewhere, they could have seamless continuation of their care, or even if they're going on vacation somewhere, and they're near a VA, that could easily be set up.
And for oncology treatment, you want to know what
Right.
they've had before and be continuous.
Right.
I would say for palliative care, it's probably half a day or a day to get somebody connected somewhere else, but we still can do it.
And it was so funny. This person sent us an email from Kentucky, and we have the Skype capability in VA internet. So I connected to Dr. Hunt and in Bronx, and within 5 minutes, everything was connected. So when we joked about it, they said, "Oh, we have to do a system redesign to cut it down to 1 minute," because we do system redesign for everything. So
I want to thank all of you, and Dr. Aytaman, Dr. Doratsos, Dr. Beal, Dr. Leaf. I want to thank you for taking time out of your day and bringing us all of this pertinent information. And it really works for the veteran. It really does. You guys are doing an enormously admirable job in servicing our veteran. And I think about it, if I knew there were this many people that cared about a veteran when I got out of the service, I wouldn't have went and hid. I came out of Vietnam, and it was a terrible time. It really was a terrible time for the veteran. People calling you baby killer and whatever, So I just went into my life and continued from that point. And now realizing there are so many people who really, truly care about the veteran and their health, it makes such a difference. And I think I missed out on a lot of years myself, and I'm sure a lot of Vietnam vets did miss out on a lot of good years. So I can't thank you enough for what you do for the veteran. I can't thank you enough for being here to tell people how they can take care of themselves. And that's really the bottom line. You can take care of yourself because there are people that want to help you. So, and Paul, I can't thank you enough because Paul put it together again. He just keeps doing wonderful things for us.
Doctor put this one together.
thank you, for having us.
As we said before, our veterans have taken care of us, and it's our honor and privilege to take care of them.
Well, I thank you for that.
Absolutely. Absolutely.
Well, you've been watching in honor of. We thank you for watching. We tell you keep watching because we will continue to bring you programming that is helpful to you and your life and your health. And God bless.